Just a way of introduction, my name is Oliveira. I'm trained in economics and health economist at the Center for Addiction and Mental Health, and located in Toronto. I'm also an adjunct scientist with the Institute for Clinical Value Sciences, which is the organization that holds our administrative healthcare data in Ontario, and that I'll be using in today's presentation. And then I have an appointment at the Institute for Health Policy Management and Evaluation at the University of Toronto. I'm happy to take questions throughout the talk. So I will be looking, it's difficult to hear, so maybe increase the volume of my own voice. Hopefully that's better. But as I was saying, I'm happy to take questions throughout the presentation, both from the room and online. I'll probably take a look every now and then to see if there are any questions online. I like to do that just because if you have a question that's pertinent to the slide I'm speaking to, we might as well address it. But again, I've also been told that some questions are left to the very end, so I'm happy to take them at the very end as well, because I will be presenting about, I think, 40 minutes worth. So we'll certainly have time at the end for discussion. And I'm actually just telling Nicole, I look forward to any and all feedback, actually. Not that it's work in progress per se, but it hasn't been completely finalized. So if there's any feedback, I'd love to incorporate it. So what I'm going to talk a little bit about today is about the opioid epidemic, which I think is a very hot topic these days. I mean, if you've looked at the news this morning, there are some jurisdictions within Canada where it's a bit more problematic than others, and I'll actually allude to that at the very end, so to say, in terms of next steps. But it's certainly a hot topic that everybody is talking about, and apparently last year in Canada, about 4,000 deaths due to opioids, so very big problem. Okay, and in particular, I'm going to be talking about the role of physicians or their prescription patterns in terms of within this context. And so this is a classic topic that we like to examine in economics, is the behavior of rational economic agents, one of which are, for example, physicians. Okay, and as mentioned, I'll be looking at data from Ontario. Let's see if I can. Okay, and then obviously opioid use related deaths have increased dramatically in both countries, and as I said, I cited that 4,000, which I think it was in the news this morning actually, 4,000 deaths last year in Canada. So obviously everybody is sort of scrambling to find solutions to address this problem. Policymakers are certainly thinking about this. Health Canada is certainly thinking about this, as is our federal minister. But what's interesting is some evidence is suggesting that the increased opioid use may be driven to some extent by physician prescribing patterns. And I'll talk a little bit about that, about what's in the US. And so it seems to be, the physicians seem to be playing a role. And so I was curious, well, is that happening here in Canada? Yes or no? And I'll talk a little bit about my hypothesis in a bit. But as I said, recent research in the US suggests that there may be a role for physician education in addressing this epidemic, but there hasn't been any evidence for Canada so far, at least not that I'm aware of. If anybody knows of any studies, please let me know. Okay, so in terms of a brief literature review, so again, one study in the US, Barnett et al., using Medicare data for emergency department visits, they found that long-term opioid use was significantly higher amongst patients treated by physicians with higher propensity to prescribe opioids. And then in a more recent study that was published, I believe, this year in the American Journal of Health Economics by Molly Schnell and Janet Curry, they found that, again, using data from the US, that American, or at least physicians that practice in the US rather, who completed initial medical training at top medical schools wrote significantly fewer opioid prescriptions compared to those trained in not so high ranked schools, even after controlling for specialty and location of practice. So that's very interesting. And so they found that there was a gradient, that the gradient was due to education rather than patient selection across physicians or physician selection across schools. So they controlled for that with the data. And so this is the graph that I would like you to bear in mind, because this is the kind of graph that I'm going to be trying to see if we can replicate using data from Ontario. And as you can see, Harvard is at the very bottom there on the left, the bottom left-hand corner. Harvard is the top top-ranked medical school in the U.S. And as you can see, the average amount of opioids prescribed increases with, increases with with the lower school rank, so to say. So because Harvard is ranked the highest, physicians trained at Harvard on average prescribe less opioids than those trained at lesser ranked schools. And what they did is there's 92 schools in the US, and so they've sort of created intervals there. You'll also see that they've also looked at unranked schools for MDs, unranked schools for DOs, and then also foreign schools as well. Okay, so this is the gradient that they found, and this is the gradient that we're trying to see if it holds for Ontario or not. Ideally, I'd like to see if this holds for Canada, and I'll talk a little bit about that in the limitations in a while. Okay, so in terms of the hypothesis, we think that probably given the size of the Canadian physician workforce and potentially greater homogeneity amongst the Canadian medical schools, that the US findings will probably not hold for Canada. So Canada is a smaller country in terms of its population, in terms of its physician labor force. As I'll talk about in a bit, there's 17 medical schools in Canada, so a lot fewer, fewer than the US, by almost a fifth. So we think that these findings are probably not going to hold because the schools probably look a lot more similar than in the US. Yeah. Yes, that's a good point too, because we'll look at that as well. I believe that in the paper they did discuss the guidelines, and I believe that they were a bit closer. I mean, there was still some call to review the guidelines, and I'm gonna sort of mention the same here as well. But that's a good point, because if everybody is systematically higher and Harvard is still higher than what the guidelines, then it's a problem for everybody, really. But I believe that from what I can understand, from what I recall, that Harvard was more in line with the guidelines in the US. So, but yeah, that's a good point, because if everybody is higher than the guide or not in line with the guidelines, then it's problematic for everybody. Though I guess as they're showing here, it's obviously more problematic for some than for, yes, yeah. It's good. My understanding, if I recall correctly, is it's good and bad in the sense Harvard was looking better, and you can see to some extent a little bit of a jump there from Harvard to the next one. But yeah, that's a good point. Yeah. Oh, sorry. The question was, yes, I'll try to repeat the question so that everybody online can hear. So the question from the room was, are the guidelines at Harvard, for example, taught at Harvard, or rather, is the prescribing patterns at Harvard in line with the American guidelines? Because if not, then everybody is not doing well. And if that's the case, then even though Harvard is doing better, it's still not doing as well as it should. And my understanding from the findings is that Harvard is more in line with the American guidelines, and therefore it's in a better situation, and everyone else is worse off, so to say. Okay. Great. So we think that in Ontario, it's in Canada, but in this case, obviously I'm going to be using Ontario data, so obviously it's not Canadian. We can't really say for Canada, but at least in Ontario, we think that those findings are not going to hold once we do the analysis. So the objective of this work was to basically replicate and extend to some extent, and I'll talk a little bit about the extensions, to replicate the work done by Schnell and Curry using data from Ontario, which is Canada's largest province, but it is still a limitation in the sense there may be other provinces within Canada where maybe this does, maybe there may be a bigger issue there. And so we're going to examine the relationship between physician opioid prescribing patterns and medical school training, and then compare those findings to the US. Some of the strengths, as I said, I think, I believe, I hope it's the first Canadian study to look at this issue. Also, it's a population-based sample of all physicians practicing in Ontario. There are some physicians that were dropped out, and I'll talk a little bit about that in a bit. It's mostly because we didn't have data that we needed on them. And in terms of the extension, as I said, we're going to be looking at number of prescriptions, but we're also going to be looking at numbers of opioids that should say dispensed, not prescribed. They weren't able to look at dispensations. They were only able to look at prescriptions. We're able to look at both because we have those in our data. Okay. Data sources. So I know that here in Alberta, you have very rich admin data, especially here, especially with the launch of the RWE initiative here, which is exciting for everybody here in Alberta. So I know you guys have good data too, and maybe you guys could try to replicate some of this, hopefully here as well. Our data so we've used healthcare records collected through the Administration of Ontario's Public Healthcare Insurance System. These data are housed, as I said, at the Institute for Clinical Evaluative Sciences up at Sunnybrook Hospital in Toronto, in the northern part of Toronto. In particular, we made use of various data sets, but two very important data sets for this analysis in order to get comprehensive data on all opioids prescribed. We looked at the Narcotic Monitoring System database and the ISIS physician database. So ISIS is the acronym for Institute for Clinical Evaluative Sciences. I understand that it's not a very good acronym. We usually like to call it ISIS the Good. I believe they're also in the midst of changing the name. We looked at data between 2013 and 2016. That's a limitation in the sense those are the only data for which we have full data. I think that there are now data for 2017, so those data are not here, unfortunately. But 2013 is probably as far as we can go. There are some data. I think it starts, the NMS starts their reporting in 2012, July 2012, but I think the quality of the data are not as good. So that's why we're limited to 4 full years of data. So the NMS includes data on the number of prescriptions filled for opioids at the prescriber level and information on prescribers. It includes data on all opioids prescribed in Ontario. So we have all the data there basically. It has information on prescribers, which are not just physicians. They could be dentists as well, nurse practitioners. We have that information. And then for those that are for physicians, we also have their specialty. And then what we did was we took the patients in those data with the opioid prescriptions, and we linked them to what's called the ISIS physician database, so we could see who was the physician that prescribed those opioids. And so we call it the ISIS physician database, or we use obviously a lot of acronyms, as I'm sure a lot of places do. The IPDB, which includes information from the Ontario Physician Human Resource Data Center, corporate provider database, and Ontario Health Insurance Plan billing claims. And so it has data on all physicians that practiced in Ontario from 1992 to 2014. And it includes other characteristics such as their sex, their age, the year and school of graduation, so where they were trained, initial medical training, so we don't have specialization, so that's a limitation. The reported specialty and the postal code of practice, so where the postal code of where they're currently practicing, and hopefully we hope that that's pretty up to date. Okay, so we've got those data. I'm going to talk a little bit about now the physician cohort in a bit more detail. So we included everybody that graduated before January 1st, 2013 with a specialty required that required a degree of MD. And that was and those physicians had to be active during the analysis period, so they had to be working. If they weren't active, we obviously dropped them. So in terms of the physicians who we did drop from the analysis, we dropped everybody with missing data on year and school of graduation, those that graduated after December 31st, 2012, and then missing data on specialty and missing data on location of practice in 2016. and this because we needed this information to do our analysis. So in the final sample, we had just over 40,000 physicians with observations for each year of our analysis period. Excluded physicians just under 6,000, which is about 13% of all the physicians in the database, which is pretty high. Most of them were missing data on location of training. So that obviously is why we didn't use them. They were also missing other data on other things that we needed to do the analysis, so that's why they were dropped. We did try to look at them a little bit more to understand whether there was any kind of systematic biases in dropping those physicians, whether dropping them may bias our results. We found that 31% did not prescribe opioids at any point during all 4 years, so that's about a third of those that were dropped. 2/5 of those were GPs. Also, what's interesting is amongst those that did prescribe opioids, the average number of opioid prescriptions was about 32 opioid prescriptions, and including zeros, and 48 excluding zeros. So it suggests that these excluded physicians may be low prescribers, and so there could be some selection bias here. I'll touch upon this a little bit later on, but that's what our excluded cohort looks like. Like I said, we really couldn't use them because we needed information, certain information that they just did not have. We used Statistic Canada's postal code conversion file and Canadian census data to link the physician postal code of practice to the respective census division. In Ontario in 2016, there were 49 census divisions, and then we obtained information that we thought would be pertinent to characterize the location of practice. This very much in line with some of the stuff that Schnell and Curry had done, and so we looked at, for example, population density, percentage of population with a high school diploma or less, percentage of population unemployed, percentage of individuals in the lowest neighborhood income quintile, percentage of individuals living in a rural setting, and then percentage of individuals living in Northern Ontario. So basically those living in the Northeast and Northwest local health integration networks, which are two regional health authorities, the most northern regional health authorities in Ontario. We have 14. These cover pretty much most of the north, and they're large areas, but obviously they have smaller population. So that's what we use for the physician cohort. Okay, let's now talk about medical school rankings. So we've talked about one side of the equation. Let's talk about the other side, so to say. We want to understand the medical school rankings. How do schools rank, and whether they're ranked or not, for example. So as I said, in Canada, there are 17 medical schools. 6 of them are in Ontario. And what we did is we obtained data on medical school annual rankings from 2013 to 2017 from the Maclean's magazine. So every year, apparently, Maclean's comes out with the ranking. That was actually the only information that we were able to find. So we hope that those are pretty good. And then what we did was, in line with what Schnell and Curry did, we created this composite medical school rank variable based on the average of the school rankings across all 3 years. And I'll show a graph in a bit to see how good that was. It was good, it was better in some cases than others. But basically, based on that average school rank, these are the ranks that we got. So there's 2 schools that were not ranked, or at least not in Maclean's. So we classify them as unranked, which are Memorial University of Newfoundland and the Northern Ontario School of Medicine. So those 2, there was no scores. Amongst those that did have scores, it seemed McGill was considered the highest medical school every year, followed by the University of Toronto, University of British Columbia, and so forth. And then we also had foreign medical schools as well, and we classify them into 3 groups, essentially. One, the U.S., just because of the sheer size of the country and because of the border, obviously, a lot more Americans make their way here. We also had another one, which is basically sort of other countries that spoke English, UK, Ireland, Australia, New Zealand, and then other international. Any questions? Just in terms of, I'll show the graph in a bit, and you'll see hopefully everybody can see that. I think it's a bit small, but as you can see, McGill was consistently over the 4 years ranked top school. It looks like UBC in Toronto switched a few times, but there's a lot of consistency amongst the up to the sixth school, the ranking of the sixth school, and then after that it starts getting a little bit. It seems to shift every year, and so what we did was a composite variable where we looked at the average. So again, we hope that that's relatively okay. As you'll notice too, because we have fewer schools, we looked at all of them individually, as opposed to what they did in the US. They had 92, so they had to calculate, they had to construct these intervals. We actually looked at all of them. So we actually do have data on individual schools. And I will be pointing out some schools in a bit because there are a few outliers which are worth mentioning. And so I understand that that could be a bit problematic in some ways. Okay. Any questions on that, the medical school rankings? Okay, let's look at the analysis. We did descriptive and regression-based analysis. So in terms of the descriptive analysis, we produced summary statistics of annual physician-level prescription outcomes, total number of opioids prescribed in Ontario, total number of opioids prescribed by physicians, and then average number of prescriptions for physicians with and without zero, so with and without prescribers. Some physicians prescribed in some years but didn't in others. Again, we replicated the analysis by Schnell and Curry. We examined the relationship again, as I said, that first graph that I showed you from their study, that's really what we're going to try to replicate, and that's what we did here. We examined the relationship between number of opioid prescriptions and medical school ranking. Given that GPs are one of the highest or account for most of those prescriptions, so about 80%, we examined GPs separately as well. So we looked at all physicians and then separated GPs. Also, we tried to do what Schnell and Curry did, try to control for whether or not there was some patient sorting across physicians or whether there was some physician sorting across medical schools. And so then we tried to also estimate opioid prescriptions by medical school ranking for the top 8 prescribing specialties and characteristics of census division of practice. And so I'll show that as well. In terms of the regression analysis, so we did the descriptive piece, but then we obviously wanted to control for a bunch of things to ensure that the findings actually were held or not. So we undertook some regression analyses, and where we controlled for specialty and location of practice. To control for differences in patient needs, we also modeled number of opioid prescriptions conditional on specialty and census division of practice. So what we did was we pulled the data from all years. And we estimated the following equation, where Y is the number of opioid prescriptions, and then we have this rank variable. So obviously it takes on the value from 1 to, it takes on the, the McGill is is going to be the control, or the reference case rather, and so everybody is then ranked in relationship to McGill. And then we have dummy variables for the unranked schools, and then we have dummy variables for the foreign schools, and then we controlled, as I said, for specialty and location of practice. So we estimated equation 1 by OLS, with and without zeros, for all GPs, for all physicians, and then for GPs separately. And then we also estimated that equation for the top 8 opioid prescribing specialties, again, including zeros and excluding zeros for all physicians. And then for GPs separately, where for GPs we also included subspecialty fixed effects. And then because obviously physicians could have had same data or could be repeated in that pooled cross section, or those pooled cross sections, so to say, all standard errors were clustered by physicians for all regressions. Okay. As I said, the previous work was not able to look at number of pills included in each prescription, so dispensation really, and wasn't able to look at strength as well of those pills because they didn't have those data. So there may be cases where one prescription may include many drugs or vice versa. So because we had number of opioids dispensed, we reran the analysis on opioids dispensed. There were some data on strength as well, but the data actually weren't that great because it wasn't consistent, and I think it's like a free text kind of variable. So we didn't really use data on strength. We may do that if we get a chance. I mean, the data were just not great. So while we did reran the analysis on dispensation, with the previous study did not do, we didn't look at strength. And I think that's something that is important to note, and we probably might want to look into that if we're able to clean the data a little bit better. So that's what we did. Okay, let's look at some of the results. So here, what we have is what we have here is total number of opioid prescriptions in Ontario for the 4 years of our analysis. And so, as you can see, there was a high in 2014, but since 2014, the number of opioid prescriptions has been decreasing over time, which is good. And I'd be curious to see if we had data in 2017, which I think we do, where that data point would sit. Hopefully it sits a bit lower as well. And so I think we are moving in the right direction. Hopefully we're moving in the right direction in the sense if we are prescribing opioids, it's for cases that are required, and we're trying to address this epidemic, so to say. So it looks like we are. Obviously, once you compare the levels to the U.S., obviously, it's one province versus the entire U.S. Obviously, they're much lower, of course. Yeah, and that's a good question. Actually, I haven't had a chance to look at that and to speak with a colleague of mine that would have more information, but that's a good point. I don't know. Yes. Oh, sorry, just to repeat the question for the for those of you online, a question here in the room was asking why 2014 is so high, and so I'm not sure. That's certainly something that we want to look into to understand why that happened, especially because 2013 was lower, and then it increased in 2014. So that's something for us to definitely to look into. But what's interesting is it has been decreasing, and would be interesting to understand too. My understanding is, it was more recently that we had, and I'll allude to that, a meeting that was organized by the federal minister at the time, Jane Philpott, talking about, okay, this is an issue, we need to start thinking about this a little bit more seriously. So it's interesting to see that sort of has started to decrease before that, and it's obviously, I'm assuming that's just because it's become an issue, and we're addressing it in some parts. So yeah, that's a good question. Yes. I'm not sure. So the question was just that was asked is whether there are any changes in practice guidelines, and I don't think so, because I think that after the meeting with the minister, that then was the issue is like, okay, we need to review those guidelines. Yeah, that's a good question. Yeah. Yes. 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 Yeah. Yeah. Yes, exactly. That's a good point. So the question here was just, was just mentioning that the CDC guidelines came out in 2016. So one of the limitations is the fact that we just don't have those data before. I guess we could potentially look at this using the Ontario Drug Benefits Claims data. The only issue with that is it's not going to cover all the entire Ontario population that would be using opioid prescription, or that would be on opioids. It would only include people that are 65 and over, and essentially those on social assistance under the age of 65. We could actually look at that, but you're right. I mean, what we have here is a snapshot of what's happened, and it'd be really interesting to look at what's happened before 2013. No. Yes. 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 It's a different. Yes, yes, which is what I'll show in a bit. Yeah, this was more sort of just to give you a sense of how things are going over time. But yes, I mean, for example, in the U.S., they were able to use more years of data, and so they actually were able to show that there's been a decline over time. But it's because things have been happening. But I think it was stable and then it declined. So they had more years of data, so they have that advantage. This is just to give you all a snapshot of, or just to give a sense of the levels, so to say. But yeah, that's a good point. And if we were able to overlay this with the ODB, for example, the Ontario Drug Benefit Claims Database, again, the numbers are going to be lower, but maybe that might be able to show us a bit more in terms of the historical trend, which is important to bear in mind. But what I think is going to be more interesting is this graph here, where here we do look, what we have here is the descriptive analysis only, where we have opioid prescriptions by medical school rank. In blue, we've got the ranked schools, which are 15. In red, we've got the 2 unranked schools in Canada. And then in green, we have the 3 foreign clusters. So the first one is the US, the second is the 4 English-speaking countries, UK, New Zealand, Australia, and Ireland. And then the other green dot is the international. I've pointed out McGill, who is considered the top medical school, and so they're actually not the lowest, as the case in the U.S., where Harvard was the absolute lowest. Some of you may be wondering, who are those schools that are below McGill? I can tell you that it's University of Saskatchewan, and it's the 3 other medical schools in Quebec: Université de Laval, Université de Montreal, and Sherbrooke. So those are the lowest ones. And what we find here is really interesting is we don't see that increasing trend. Yeah, it looks backwards. I know, which was sort of like, oh, okay, that doesn't make sense. I'm going to show you another set of graphs where I've tried to, rejig the data to think about, okay, let's try to think about this. But yeah, it looks backwards. So it's just like, wow. Well, yes, exactly. And we'll get there in a bit, but that's what I was hoping, is to see it flat. It is pretty flat. I mean, it's not as stark in the US. I mean, what is stark though is there is that one outlier over there, which is the Northern Ontario School of Medicine. There, amongst the ranked schools, there's one that's a little bit higher too. That's Western. How many physicians? I think they train about 80. So we're looking at outliers here. Yeah, we're looking at outliers here. Yeah, I mean that's one of the smallest medical schools. Those other ones are much larger. Yeah, 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 yeah. Yeah, yes, yeah. I know exactly. I know, which is why when I was presenting this, I did want to sort of with a grain of salt. Okay, so you brought up a good point in terms of it is flatter than the U.S. and I guess it would be it's sort of in the opposite direction of the U.S. Not in terms of the direction we were expecting. We were expecting flatter. So what we decided to do is rejig the data in such a way that let's look at the gradient only amongst the Ontario schools. Given that they are practicing in Ontario, let's look at the schools that are in Ontario. And what now we see, I mean, obviously not a huge gradient, but now we see sort of a similar gradient to the U.S. Not quite the same, but then when you look at non-Ontario schools, you basically see that there is no gradient. But these are the descriptive analysis, and I'll provide more in terms of descriptives. For the top, yeah, yeah, yes. At least we're consistent, right? And we'll see that in a little bit. We'll see more of that in a bit. Here are some descriptive stats by for the top 8 specialties. Well, actually, I didn't really. It's a huge table, so I wanted to summarize it. And then also prescribing practice characteristics by medical school rank. So in terms of specialty, GP was by far the largest specialty, then followed by obstetrics and general surgery. What's interesting is our top 8 specialties actually don't really align with the ones in the US, which I thought was interesting. In terms of population density, so I wanted to look at where there was the most versus the least, so to say. People trained at U of T and US trained tend to end up practicing in places where there's more people. Those that are trained at NOAHE where there's fewer people. The NOSM trained physicians are also in places where the percentage of people in high school or less is higher. U of O is where the percentage is lower, so to say. So as you can see, physicians trained at NOSM, for example, tend to practice in areas that have higher percentage of high school diploma or less, for example, higher percentage of unemployed individuals, higher percentage of low-income quintile, and then rural and then Northern Ontario as well. So also where these physicians, they get trained at schools and then where they end up is also very different, right? And those that are trained at NOSM tend to stay in the north, so to say. That's what they're trained up there and then they just stay there. And as you can see, other schools, for example, if you're trained at U of T, it looks like you tend to stay in Southern Ontario. Okay, so now let's look at the regression analysis. So as I showed you before, that was this descriptive stuff. I wasn't controlling for anything. I was showing you the raw data. Now in this case, we've actually controlled for things. We've controlled for specialty. We've controlled for location of practice. And now, as you can see here, what happens is that gradient disappears. What's also interesting here too is a lot of those coefficients actually are not statistically significant. The one in NOSM is actually when you include zeros, but it isn't when you exclude zeros. But all this to say is now it goes back to your point. So our hypothesis is true. We are sort of consistent, which would make sense because it's a relatively small country, small physician labor force. So here just, yeah. Looking at the number of prescriptions. Yeah. Average number of because we look, that's the rank there. So what we're looking at is average number of prescriptions by school rank, and so everything is with McGill as the reference case. So we did what. Yeah, exactly. So sorry, yeah. So the reference case is McGill, which is a top-ranked school. So everything is in relationship to McGill. So we put McGill as a 0, and everything else is above that. So exactly, the difference is it is average number of prescriptions, but in relationship to the reference case, which is McGill. So I'll provide here a bit more summary of what we found. So when we look at all schools, we find no gradient. However, NOSM is still a high prescriber, an outlier, even after controlling for specialty and location of practice. As I said, most of those coefficients for school rank are actually not statistically significant. So once you start controlling for stuff, we're not really finding much. When we did that analysis, Ontario schools only versus non-Ontario, we see increasing gradient. But again, the coefficients are not statistically significant. So it doesn't really matter. Similar findings for GPs as well. When we exclude the zeros, fewer statistical significant coefficients. In this case, the NOSM coefficient now is no longer statistically significant. So we're really not finding anything. And then when we look at this by specialty, again, no real findings because, again, a lot of the coefficients are not statistically significant. So you start not really finding anything, which, again, is sort of leaning towards our hypothesis. Yeah, so the question was asking about differences in prescriptions and how it might vary by different time periods and months. I mean, what we looked at is we looked at every physician, and what we have is an annual average. We didn't go to that level of granularity, though I suppose we could because we would have those data. So we didn't look at that actually. We only looked at it by year. Yeah. Right. Mm-hmm. Mm-hmm. Yeah. Yeah. So I'm just going to repeat some of the stuff. So we were just talking about the effects of seasonality, and someone in the room had mentioned that we would probably see some higher peaks of opioids in the winter, but that's probably has changed in the last few years. But again, we didn't look at that. We looked at annually, and someone here in the room pointed out that annually is probably going to look a lot more with less peaks, obviously. There was another question too in terms of how do we compare to the U.S. And so when we look at the average number of prescriptions, uh, we're lower. We are lower than they are. So I think we're not doing horribly but I think that the average number is relatively low. The thing is, we're also looking at only on Ontario, right, which is really small, and they're looking at the entire U.S. But I believe that the average number of opioid prescriptions per year, mind you, they also had more years of data, but I believe that our average is a little bit lower than theirs, at least for the schools that are not ranked as high. I can't recall how we exactly compare to Harvard. I'll have to double check the numbers. But in terms of some of the higher prescribers, we're not doing that poorly. In Ontario, again, this might look differently in other jurisdictions in Canada. Okay. Okay, so let's shift gears from prescriptions and let's move to dispensations. Again, we're sort of finding the same thing with dispensations in the sense we find that opposite sign. But then again, but this is the descriptive analysis, so we haven't controlled for anything. So let's wait and see what happens. We do have an outlier there, but it won't matter because once we do the regression analysis, that coefficient is going to be not statistically significant. So again, we're back where we started, so to say. So interesting stuff here by dispensation. But then once we again control for all the stuff that we've controlled for in the other regression, we basically we do see that decline there over time, like that. But again, essentially all of the rank coefficients are not statistically significant once we control for things. So, and it was the same thing when we did it for GPs only, the same thing for excluding zeros, and it's the same thing by specialty. We're not finding anything contrary to the US. I mean, the study in the US, like they found all kinds of stuff, which is interesting in the sense they're finding stuff that's not good because it's not good stuff, obviously. So very alarming findings. We're not really finding that using Ontario data. Okay, so in terms of just discussion points, so rank of school and country of initial medical training on opioid prescribing among physicians in Ontario is not as strong in the US. If anything, I mean, we're not finding any gradient whatsoever. As mentioned, there are fewer medical schools in Canada. I mean, it's 17 versus 92. It's almost like we have one-fifth of the schools that they have. I would assume that there's less heterogeneity in training. Basically, same findings when analysis is done by specialty. We're just not finding anything. And they found stuff. They actually found that the gradient by some specialties actually still held, which is really interesting. For some analyses, physicians trained at NOSM were higher prescribers when compared to those trained at other schools. Dispensations, we did find that one outlier, but then that didn't hold once we controlled for stuff. So, not worth probably talking too much about that. Not wanting to pick on NOSM, but I guess previous work has found higher opioid use and opioid-related deaths in Northern Ontario. Some work done by the Ontario Drug ODPRN Performance Research Network. I think I got that wrong, but it's a group in Ontario led by, for example, Tara Gomes. One of the leads is Tara Gomes. They found that also Northern Ontario is also the region where, as I said, most NOSM trained physicians remain. So maybe there may be a need to revisit the NOSM curriculum. Maybe not now, actually, because I'll show you in a bit. Maybe they've already revised it in the meantime, because we have had recent nationwide efforts on behalf of medical schools and physician training programs to improve training contents on pain management, opioid prescription, addiction and substance use disorders for practitioners early in their careers, but also continuing education for the current practicing physicians. And in particular, in November of 2016, as I mentioned, Health Canada and the then Federal Minister of Health, Dr. Jane Philpott, they held the Summit on Problematic Opioid Use, which included Association of Faculties of Medicine of Canada, which includes all 17 faculties of medicine, and all of them committed to improving foundational core competencies in medical education as it pertains to opioid prescription and pain management. So the findings that we've just seen today are up to 2016. This meeting was held at the end of 2016. Things would probably have changed once we look at data from 2017. I think we have those data, so it may be worthwhile to throwing it in to see what happens. But you know, maybe that suggestion that I've said about revising the curriculum, maybe that's already been done. Actually, so I think we have 2017 data now, so we'll throw that into the mix, and maybe some of this actually will no longer hold. So as I said, given the time frame, the results may actually differ with more recent data, and so maybe it's not as problematic as well. It wasn't really problematic here in Canada, in Ontario. So some of the limitations of the work, which I think I've sort of alluded to throughout the presentation, and now I will fully recognize them. We weren't obviously able to examine all physicians practicing in Ontario. About 13%, which is a pretty large percentage, had missing data on medical school of training. Again, among those excluded physicians, the average number of prescriptions was lower than that of those that were included in the analysis. So we could have some selection bias, which we did not control for ultimately. But I think that would have been more problematic if we had actually found it. If we were finding the same gradient in the US, then you could say, well, you've excluded everybody that is not a high prescriber, so your results probably don't hold. So if you probably throw in these low prescribers, assuming that they had all the data, you probably would find even in the descriptive analysis, you could potentially even see a flattening of that. Though again, in the regression analysis, we found nothing. Yeah, we could do that. Yeah, so the suggestion was just to throw in that 13%, even though they have unknown school, to throw them in and see what happens. As I said, we did try to do an in-depth analysis of these excluded, because I know that people come and say, well, if you've excluded everybody that's a low prescriber, well then you've just sort of biased your results. But we did do an exhaustive analysis. But yeah, we can do that as well. Also alluded to earlier today during the talk, we only had complete data rather, for 4 years at the time. I think there's probably data for 2017, which would increase our time points to 5. But again, we don't have that historical data, which probably would show us some very interesting stuff. So it is limited in that sense. Only able to observe where each physician completed initial medical training. And so not where they obtained specialty training. So maybe they were initially trained at one school, which could have not been great, but again, there's not a lot of heterogeneity, and then got specialty training where that they did get good training on opioid prescribing, and that may have changed stuff. But the thing is, we also did look at specialty, findings by specialty, one of which, for example, which requires significant training in pain management, like anesthesiology. We didn't find anything anyway. So, I guess, even though we weren't able to look at where they obtained specialty training, we really didn't find anything by specialty. Also, even though we had information on strength of opioids, which was not available in prior work, it wasn't in a very usable way. It wasn't in a usable manner, and so we didn't include it for this analysis. We may look into that, but the data were just not in a good format. But then again, we might just find more of the same, which is really nothing. As I said, even though Ontario is the largest province, as of January 2017, only 36% of all physicians in Canada practice in Ontario, so we are limited because we only looked at one province. We can't really say that this is what's happening in all of Canada. So that's another limitation. Also, we only examine physicians and not other healthcare providers who can also prescribe opioids, such as dentists, nurses, nurse practitioners, midwives, optometrists, pharmacists, and chiropractors. They're all in the data, actually. What's interesting, though, is in the NMS, Narcotic Monitoring System database, the vast majority, 98% of all of the prescribers are physicians. But I did see a study where they were saying that dentists may actually be proportionately larger prescribers of opioids, at least in the US. So that might be interesting to look at, maybe future research to try to understand how these prescribing patterns, how they look like among other professionals, maybe dentists. we probably are not going to get a really big sample if we try to do that. The thing is, I don't think we're going to get school of training for dentists because we don't have that in our database, in the ICES physician database. So, but I thought I'd throw that out there because we didn't look at all of them. Also, it would be really interesting to replicate this analysis in other provinces where this is a bit more problematic or where we have good data. So obviously, BC, I think, is one of the provinces where this is a bit problematic or maybe more problematic. I don't know if they have data on that. I think Alberta also might be another place where to look at this. You have good data as well. So that would sort of be, I think, future research is to, try to replicate this for other provinces. We can't pool data from all of Canada, at least not in an analysis like the US did, because their data cannot leave provinces. I think it can actually here in Alberta, but under very strict conditions, I think. I don't know. I heard something around that. But maybe a meta-analysis of some sort. I'm not sure. But as I said, I think future work, to replicate this in other provinces to see if that is problematic or not. So that's all I have for today, and I'm happy to take more questions. And I'm very happy to take also more to take more feedback because as I said, as I was telling Nicole, this is the first time I'm presenting this work, so I'm very keen to hear your thoughts and what I could do more to improve this if possible. I will be presenting this as well at the European Health Economics Association meeting in Maastricht in July, and if I have time to redo some of the analysis for then I can address it for that other presentation. But yes, happy to take more questions. Okay. Yeah. Okay, so I'm going to try to repeat that if I can. So the question was whether in the data set in the narcotic monitoring system, whether I could differentiate between different types of opioids. And then the second question was in terms of specialties, whether I looked at addiction medicine and oncology. Okay, great. I'm glad that I got that all right. So in terms of the first question, so yes, the narcotic monitoring system includes all narcotics. Obviously, we can't control for things. These are things that are prescribed. So, I mean, if someone's taking opioids that have not been prescribed to them and through the black market or whatever, obviously it's completely out of the question here. I can't, to be honest, I can't recall whether they've differentiated between, but I'm going to say yes, that we can differentiate between because I think we have that level of, we probably didn't, but the data set has that. So that's a good suggestion is to, to see if we can do the analysis by different types of opioids, because I believe that we do have those data, but we didn't do that. So that's a good point, because it'd be interesting to see whether there are any findings there. In terms of the different specialties, one of them was oncology. So we looked at the top 8. I can't remember. I think there are 53 specialties in the ICES, and you might know better than me because you're an actual, you work in the field and you know this more than I do. I think there's 53. At first, we looked at the top 20, and then we looked at the top 8. And again, I was trying to replicate the US. Oncology, I think, was amongst the top 8, at least the top 20 for sure. And I don't know about addiction medicine, I can't recall, but we did do it at least by the top 8. So I'll definitely check a bit with addiction medicine and oncology. But assuming that they're in the top 8, the coefficients on the rank, which is what we were interested in, on the medical school rank, most of them were statistically insignificant. Like sometimes we'd get one school So that's sort of hinting to me that it doesn't really matter where they got it. So, but I'll definitely check those two because I can't think off the top of my head. But I know anesthesiology was one of them, GP and surgery, pediatrics as well, which is like wow, pediatrics, psychiatry, those for sure. So thank you. Those are good questions. Very good suggestions. Yes. Yes. No, no, that's a good point too. So they were just asking whether, so for example, in the regression analysis, oh, I can't go back, but okay, it doesn't matter. We looked at, so it was average number of opioid prescriptions, and so the question was whether or not we used other kinds of models. So for example, whether we used Poisson or negative binomial. We did not, which is a good point. We used OLS mostly because, well, on one hand, because we wanted to replicate what was in the US, and so to make sure our findings were or to try to see if we could do the same thing. So we used OLS. I think there's also cases where I think the range is just so high. I mean, there will be zeros, but there are also like very high numbers as well. So we just thought, OLS. We can certainly try that as well. I'd be curious to know actually whether or not those would perform better or not. Just because, OLS in a lot of times does perform quite well, especially when you've got a continuous well, a count outcome, but that takes on many values. But that's still worth thinking about. Yeah. Yeah, we can certainly test it. Yeah, yeah, yes, yeah, yeah, because we're looking at average number of opioid prescriptions. Yeah, 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 yeah. In Ontario. Yeah, hmm, yeah, yeah. Yeah, yeah, no, those are good points. I'm just going to repeat some of the points that were made here in the room. So the first point was it'd be really interesting to see how Canada compares to the US. And so the example that was given is, are we at like the level of Arkansas, University of Arkansas, or Yale or Harvard? We will be able to look at, so that's a good question, which we'll certainly look at. We will be able to look at how we fare compared to Harvard because Harvard's been pulled out. Other schools are in intervals, but still we can see which interval we compare to the most as well. So we may be able to find out which schools we more look at. So that's certainly something to highlight, and I certainly will highlight, especially as we go to an international setting, that I think people will want to know that. So definitely look at that. Yes. Yeah, you're just saying that as an economist, I can make the results look any way I'd like to, so make sure Canada looks good. I think on many fronts, it looks like we don't need to do too much on that front, but yes, I mean, we'll see. Ontario might change a lot. I don't know if everyone here in Alberta knows, but we had a change in our minister. Yes, in our premier. So we'll see how things change and how good we look. The other question too, which was really good, was to highlight the fact that these are physicians that are trained in Canada but practicing only in Ontario. The example was given that the CIHR report that came out yesterday was showing that Quebec is one of the lowest prescribers of opioids, even though, for example, there may be they've been shown to be higher in benzos. But you've actually brought up a good point, because when I first showed you the schools, even though it was descriptive, the schools that were below McGill, so McGill was considered the highest ranked school. The schools that were below McGill were actually all of the Quebec schools. So I don't know if that has anything to do with it too, right? Because the thing is, some of them obviously make their way to Ontario, but I'm sure a lot of them, those that are trained in Quebec, stay in Quebec, especially probably in the Francophone universities, right? So maybe that maybe, I don't know, says something into that. I don't know. Yeah, 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 yeah. So the other thing too that was just being mentioned here is just to mention that the culture in Quebec is very different. So even though we're looking at initial school of training, which seems to look the same across the board in Canada because we're a small country and very homogeneous rather, um, to think about culture of the place where they practice, that is what's likely to change across the country. And as was mentioned in Quebec, for example, it's likely to be the case that the culture there is very different from the rest of the country. And the fact that the Quebec schools, even though they were training Ontario, but were trained in the Quebec schools, they were lower. Maybe that is exactly what's happening in Quebec, is those that are trained in the Quebec schools, especially the Francophone ones, remain in Quebec, and that probably might be explaining in some part the lower opioid. I don't want to sort of, put all of my findings and say, oh my God, the physicians are all to blame here. It's just, I guess, as the U.S. saying, maybe there's a role for them to play as well amongst all the other things that are happening in this context. So I think I've captured all. Yeah. Okay. Great. Thank you. Yeah. We did have that. I'm trying. Can we go back to? Oh, great. Thank you. That so. So the question is, amongst the ones that are trained in the U.S., how they compare to Ontario. So if we look at the regression analysis, now I'm on slide 18. The very first green triangle is actually the U.S. schools. So these are people trained in the U.S., practicing in Ontario, and they, compared to McGill, they're just slightly a bit higher. So they're actually quite low. Well, at least they're looking, well, they're looking like our top ranked school, so to say, very close. But that's the U.S. aggregate. I would be interested to know, amongst the U.S. trained physicians in Ontario, where are they coming from? Which schools are they coming from? So it might be worthwhile if we can. Yeah, and I think actually that we can find that out. I believe that we can actually. So actually, that's a really good point to see, because, if, for example, if they're all coming from Harvard, that's a good thing in the sense Harvard was shown in the other story to be low prescribers, and we're getting sort of the best and the best, well, the ones that practice more the way we'd like them to. It's a good point. I don't think the NMS actually has cost data, because I think at the time we had asked about that. That's, I think, one of the limitations of the narcotic monitoring system, which is not the case with the Ontario Drug Benefit Claims Database. They have a unit cost in there. I believe that the narcotic monitoring system does not have the cost, so that's a good point, which I didn't make reference to. I don't think we have that information, which was actually one of the things that we wanted, and then we found out we just couldn't do it. So that was unfortunate, or that is unfortunate. They are. Sorry. Yeah. Yes. 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 If I take out all yeah, yeah. Mm-hmm. Yeah. Mm-hmm. Yeah, no, those are good points, and I'm just going to repeat it. So, and I'll answer as I repeat it. So, for example, just bringing out the point that, for example, NOSM, the main, I guess their main objective is to train GPs. You're right. In the data, without sort of disclosing but pretty much every physician that was trained at NOSM is a GP. So so that obviously makes a lot of sense. That in that case, the specialty it is GP. You don't. I think there was basically it was all GPs. The other issue too is, for example, if we were to exclude all oncologists, what would happen? With the data, and we didn't do that, so that's a good point. So we could rerun the analysis just on the on all of them without the oncologists and see what happens. We can certainly do that. You also suggested that we run the analysis with only without the GPs. Without the GPs, correct? Pardon? Without the treatment drug. Okay. Which we can do as well. And then you also mentioned the fact that in the north, for example, we do have, which is very true, we have a larger proportion of First Nation populations up in the north, and a lot of them may be on methadone. And so that's something to think about as well as when looking around that as well. So those are all really good points. Yes. Okay. Mm-hmm. Okay, that's a good point. Okay. The year, okay, yeah. So one point that was made was just to be sure to define who is a GP, because that might differ depending on the jurisdiction. So we'll certainly look into that, as opposed to could be CCFPs, right? So we'll that's a good point. The other question too was about years into practice, and I believe we do have that data, and we didn't look at that. So that could also be something to look at. I can't recall if we controlled for physician characteristics and stuff like that, but I'll certainly look. Yeah, because I think initially we were trying to do just a pure replication of what they did in the US, but that's a good point because especially, maybe younger trained physicians have a different kind of approach to this issue than physicians that were trained a long time ago, for example, because obviously things have changed and this has become a bigger issue in the last few years. So I believe that we do have those data. I think we have, yes, we do, because we have year of graduation, so we do. Yeah. Yeah, we have years of graduation, so that was just. Well, especially nowadays, right? So just mention that the younger you are, probably the less likely you are to prescribe opioids, and I think even more so after the summit that happened in November 2016. So that's a good point. Yeah, physicians might be a bit more reluctant to just prescribe opioids. They might want to have a very good case to do that. So yeah, that's a good point. Thank you. Any questions online now? They probably would show. Okay. Okay. Good.